I'd like to next invite Dr. Shou-Ching Tang, who is Associate Dean for Translational Research at LSU. He's the Francis Zappardo Endowed Professor in Cancer Research, and he's the Director of Phase 1 Clinical Trials at LSU. He's been in basic science research for 40 years with his PhD. He's been in clinical practice for 30 years, and he's very active in SWOG and in San Antonio Breast.
Good afternoon. It's a pleasure to speak at the CAGLA meeting. I want to thank the meeting organizer and Dr. Cosetti for the opportunity. We heard two great talks earlier, one on early breast cancer, one with metastatic disease. We've made a long progress towards curing breast cancer in my 40 years of career in breast cancer research. And what I'm going to do in the next 20 minutes also is to tell you what's around the corner, what's in the future. We want to make the patient, the young patient that lived 10 years, we want to make her live 20, 30 years and beyond. So this is what I'm going to talk about, drug development in breast cancer. Now, I'll, of course, briefly go over the breast cancer growth signals and the drug resistance mechanism. I'll focus my discussion on three groups of breast cancer: HR-positive breast cancer, HER2-positive breast cancer, and triple-negative breast cancer in terms of drug development and where we're going. And due to time constraint, I won't be able to talk about ADC and some special consideration for breast cancer biomarker testing, including the HER2 no testing. Now we know that there are two well-known signal transduction pathways in breast cancer. One is the HER2, HER3 TKI. The other one is, of course, ER pathways. Those are two most important growth signals in breast cancer, and interaction between them resulting cancer progression, prognosis, progression, and eventually cell survival in breast cancer. So those are two most important pathways we try to target with the drug development. Now let's talk about HR-positive breast cancer. We published this paper 10 years ago to review all the potential drug that is going to be hot, and that include ESR1 mutation. That includes protein degrader drug that target PI3K pathway, AKT, mTOR, and even the cycling inhibitors. Of course, within 10 years, all those so-called hot topics we talked about past is now hot drugs on the market. So that shows, drug development does work, and thanks goodness for the collaboration between pharma and academia. We are making huge progress in terms of drug development in this area. Now, in terms of what's novel in HR-positive breast cancer, we know about the oral SERDs in development, and with one approved drug, elacestrant. And of course, there's another new drug in development for HR-positive tumor is the CERAN, which is a complete estrogen receptor antagonist, and together with the SERCA, which is a selective estrogen receptor covalent antagonism. Of course, there's a PROTAC that relies on the proteasome to degrade protein, including ER. There's a molecular glue degrader, or LITAC, that target the lysosome. And also, there are strategies on the way to inhibit even ER production in terms of siRNA or DNA oligomers. Using the space technology that is basically developed during the COVID, where we now can effectively transduce a mRNA or a stretch of mRNA into the cell to inhibit the target protein production. And finally, we have a variety of targeted therapy against the androgen receptor, EGFR, FGFR, HER2, HER3, CDK inhibitors, and also immunotherapy. So we wrote this review article recently, actually 2 years ago, looking at the oral SERDs, and suffice to say that almost every drug company has an oral SERD in development. Whether it's phase 1, phase 2, or phase 3, we're going to see an explosion of oral SERDs coming into the market in the next few years. And what's unique about oral SERDs is that it could be more potent than the current aromatase inhibitors, and even more potent than faslodex, although they do have their unique toxicities. Because we've been using tamoxifen, using EI for decades, and close to 1 million patients were treated with this agent. But we do not normally see some rare side effects such as cardiac problem or even eye problems, which we now do see with some oral SERDs. Whether this is a unique problem with the oral SERD, or this is just by chance discovery, we do not know yet. But some oral SERDs does cause bradycardia, and some oral SERDs cause cornea ulceration or dry eye, which you do not see with traditional tamoxifen or AI. Now, one new drug I want to highlight here is this drug from Olema. We are doing the phase 1 trial in a dose escalation fashion. It's a brand new first-in-human trial that we recently opened at the LSU. What it is it's HET inhibitor. What does HET do? It basically acetylate chromosome and open up the chromosome for gene expression. So, because as you know, DNA is wound closely up in the coil. In order for it to transcribe genes, you have to open up. So that's what the HET does. So HET inhibitor, of course, inhibit that process. So therefore, DNA coil remain closed and there's no gene expression. So we are, like I said, doing a first phase 1 trial in human as several centers in the U.S. to study this HET inhibitor in a phase 1 trial. Any patient with ER positive metastatic breast cancer and that failed standard therapy together with the non-small cell lung cancer as well as prostate cancer that failed standard therapy are eligible. So this is a dose escalation study where it's biomarker independent. It doesn't matter what biomarker you have. And another newly opened phase 1 trial at our center, breast cancer related, is this one from New Bay, which is a pan-PIM inhibitor that synergize with sotorasib or KRAS inhibitor in solid tumor. So we're doing a first-in-human trial to combine these PIM inhibitors with patients who have KRAS G12C mutation. This is any tumor, including breast cancer. So moving on to HER2-positive disease. And in HER2-positive disease, we know that there are 3 groups of anti-HER2 drugs on the market. And the one on the left is basically TKI. We have 3 TKI that target the intracellular domain of the HER2. We have several monoclonal antibody, including trastuzumab, Perjeta, together with the margetuximab, which has a unique Fc region that stimulated the immune positive tumor cells. Finally, you have 2 ADCs, that's TD1 and on HER2 on the market. So this is basically what we have now in terms of how they function at the molecular level. Now, as you know, with HER2 anti-HER2 therapy, we all have to deal with a resistant disease. When I give talks, people ask me, so how often is drug resistance? I say, since we don't have a cure, I would say drug resistance is 100% because almost every tumor will reach to this stage. Of course, there are many mechanisms of action of drug resistance, including the MAP kinase pathway as well as the P10 and PI3K and eventually mTOR and cyclin pathways. So on the cell surface, of course, the resistance mechanism can happen from anywhere from EGFR, FGFR, even AR pathways. So there's multiple way HER2 positive tumor can develop resistance. And we even did our own talk research to study the FGFR receptor and its interaction with the HER2. And we show that indeed there's a robust collaboration or crosstalk between the two pathways. And these are the summary of what's coming up in terms of anti-HER2 therapy in the works. And of course, we have some novel TKI, including paratinib, in development. And there's additional ADC against HER2 target, including the CAR T cells and bispecific antibodies and biparatopic antibodies, and additional immunotherapy against in collaboration with anti-HER2 therapy, and also even HER2 vaccines. And the key is, how do you know which HER2 positive tumor would respond to your particular therapy? So therefore, it is important to develop some predictive biomarker for anti-HER2 therapy in addition to HER2 itself. So far, we have no validated predictive biomarker for anti-HER2 therapy due to tumor heterogeneity and the complexity of drug-resistant mechanism. If you recall the slide that showed, there's a lot of crosstalks. And potential biomarker that was being explored, including P95, which is a testing. This is a truncated HER2 where it lost its extracellular domain. Therefore, it no longer binds to monoclonal antibody anymore. It will be resistant to any monoclonal antibody-based therapy such as Herceptin, Perjeta, even ADCs. But the question, should we be testing it? And that is an ongoing research. And in any patient population, it's about 30% expression rate. And also, what our loss of HER2 expression, in addition to being truncated, and of course, ctDNA to look at the somatic mutation of HER2 and PI3K, P10, AKT mutations, and MRD, multi-drug resistant or minimal residual disease testing after adjuvant metastatic disease, and also finally a toxicity sum score that we developed from our own research. What it is I'll just tell you briefly what this sum score is. We know that TDM1 is a ADC against the HER2, and with a non-cleavable linker. So it is technically non-toxic, because the beauty of ADC is that once you link your payload physically to the antibody, the drug is non-toxic unless it's ingested by the tumor and the linker gets cleaved up and payload released. But then where does the TDM1 toxicity come from then, since it's a stable linker? Of course, the only source of free payload would have come from the lice tumor cells when they released the tumor payload into the blood, which causes the systemic toxicity. Therefore, we hypothesized a few years back, if that's the case, the systemic toxicity of TDM1 should correlate to tumor response. The bigger tumor lice, of course, the more toxicity will have, then eventually survival. So we actually did a multi-center study involving even Canada, where trained in the past. And indeed, our study showed there is a correlation between the systemic toxicity of TD1 and tumor response, eventually survival. Confirming that indeed, at least for ADC with a stable linker, systemic toxicity comes from the lice tumor. So this is the slide that from that paper. So it shows that we, according to this toxicity sum score, the higher the score, the higher the toxicity, and of course the longer the patient survive. So moving on to triple negative breast cancer, and there's multiple target to against the triple negative. Triple negative cancer is, as you know, is not a unique group of tumor. It's basically simply means it lacks ERPR, it lacks HER2. Everything is got lumped into triple negative. Therefore, there are multiple potential target we can hit, and that includes the vaccines, oncolytic virus, second and third generation immunotherapy. the reason I'm marketing red is I'm going to expand on that in my subsequent slide. Of course, there's a lot of small molecule drugs in development, including drugs that target, it's called XPO1, hedgehog inhibitors, EGFR inhibitors, PARP inhibitors that was discussed earlier, and also mTOR inhibitors, and CSPG4 inhibitors, and TM1 inhibitors, Ro48 inhibitors, and including some novel monoclonal antibody ADCs against different targets, including HER2, HER3, folate receptors, and lectin-4 receptor. These are all being developed for triple-negative breast cancer. And of course, this target protein degradation being developed in triple-negative breast cancer using PROTAC technology to go after individual oncogenes. And finally, this novel hormonal therapy that is being developed for triple-negative breast cancer, including agents that actually promote androgen receptor function and target AR, and also target the novel ER receptors. And this is the paper we just published actually just 2 weeks ago, hot off the press, about what I mean by first, second, and third generation IOs. If you look at the immunotherapy development and currently in use, we're talking about hundreds of immunotherapy against different types of targets. We basically, in our review, we grouped them. We proposed the first concept of 3 generations of immunotherapy. And the first generation of immunotherapy basically include the traditional PD-1, PD-L1, and CTLA-4 inhibitors. And second generation inhibitor IO are those that I call checkpoint modulators. They function downstream from the PD-L1, PD-L1, and to modulate immune response, and that includes some targets, including the ICOS, OX40, and the CD40, which you want to enhance because those are positive signals for immune activation, versus some negative signals such as TIM3, LAG3, TIGIT. Those are molecules you want to inhibit. So any molecules that target this sort of what I call second in command is called second generation IO. And third generation immunotherapy are those that target the tumor microenvironment, including adenosine, STING, IDO, and CD47. That's the do not eat meat molecules. And FLT3 and cytokine and receptors by specific T cell engagers and the tumor vaccines. So those are the ones that act at the tumor microenvironment. So if you look at the tumor response and immune response, I always equate that as a fighting war. You usually have general up on top. That's the CDL, PD and PDL4, and in the middle, chain command, that's where the checkpoint modulator is. And of course, finally, tumor microenvironment is where the foot soldier is. You need a collaboration between those 2 generations of molecules in order to have a most effective immune attack against the tumor cells. So, like I said, I will not go over the special discussion on ADC due to my commitment with Dr. Cossetti to keep it short for the exciting case discussion coming up. So in summary, we have made significant progress in recent years in drug development for breast cancer. And what we urgently need is predictive biomarkers to guide the targeted therapy and overcome the drug resistance. Any patients with breast cancer who failed the standard therapy, i.e. stress, should have NGS to identify the targetable or actionable mutations and be enrolled in the clinical trial in order to benefit from novel agents. So this is just for the last slide, and this is my team of dedicated employee on phase 1 trial. And we have, Robert, my NP. We have Yana in the back, my research nurse, and together with the one next to me in the back is Brianna, my data manager, and the girl in front is Savannah, my coordinator. So if you to have any patient and need phase 1 trial or any breast cancer trial, and these are my team and their contact person. So I think I kept my promise to be right on time, and thank you very much. It's hard to give a talk, on drug development, in 15 minutes, but I basically gave you a bird's eye view of what's coming. Thank you very much.
So all these are real cases. They're cases we've had in clinic in the last few months. And trying to keep the theme of biology and where we're moving towards the future. I had some interesting cases from a biological standpoint to present. Okay, I think we're good. Okay, this is a 45-year-old premenopausal woman. She had a previously calculated high-risk Tyrer-Cuzick score of over 20%, so she was getting screening MRIs. In 2024, she had an MRI that revealed two masses, one in the 9 o'clock, one in the 10 o'clock areas of the right lateral outer breast. No significant risk factors from her GYN history. She did have some Lyme disease history and had a thyroid removed. The family history that was interesting, her mother had inflammatory breast cancer at age 43. The mother had been adopted, so we had no further genetic lineage. The mom was still alive, doing well, and the mom had been tested. She was genetically tested and was negative 2 years ago. And the patient's genetic testing during the workup was negative. So this patient would end up going to surgery first. So, and I'm going to show the imaging. So in the 8 to 9 o'clock region, lateral breast, 7 centimeters from the nipple in the middle depth. There was a 1.7 centimeter abnormality on the MRI. Also in the 10 o'clock region, same size area on MRI, 1.2 centimeters. These would both be proven to be positive, both strongly hormone receptor, both HER2 negative. One had a Ki-67 of 24, one had a Ki-67 of under 10. So I ordered an oncotype on this patient. She had clinically negative axilla. And I ordered an oncotype, and I picked what I thought was the more biologically aggressive tumor to test first. It ended up having the lower oncotype score. When it was low risk, we tested the other one. So one was 23, one was 25. So I took her to surgery, and we ultimately did a unilateral right nipple-sparing mastectomy, transverse radial incision. We took a narrow ellipse of skin to take a segment. You'll see on the MRI that was close to one of the tumors was close to the skin surface, so we put a Scout wireless reflector there to make sure we had good margins on that skin. She had immediate autologous tissue reconstruction. So here's her MRI. You can see that. The two tumors, the bigger, the one, they both were read as 1.7, but the one that turned out to be bigger is the upper one. Whoops. What did I do? Okay. The upper one. The sentinel node in there? I did. So we marked that lower tumor with a skin reflector, with a Scout reflector just between the skin and the tumor, and I took the skin over that. Here's the kind of the asymmetric density with spiculations on standard mammography. Here was it on MRI. This is the subtraction image, first tumor, and then the second tumor that was close to the skin. There's the Scout reflector. I took the skin there. So on her final path, her sentinel node was positive on a frozen section. She had a completion dissection at the time of surgery, intraoperatively, 33 additional negative nodes. So only one of 34 nodes positive, which was the sentinel node. And that node had a 3.5 millimeter macromet without extranodal extension. All margins were clear. Multifocal disease, the largest tumor being a T2. So adjuvant chemotherapy for this patient. To the panelists. Dr. Tang.
She had an oncotype of 25 plus a positive node, plus she's premenopausal. Right?
Correct. But and if I'd known about the node, I wouldn't have ordered the oncotype because there would be no data on getting the oncotype on a premenopausal patient with a positive node.
Yeah, she's has multiple high-risk factors. Young and 2 tumors, and sentinel node positive, and I would offer her adjuvant chemotherapy.
Yeah, so the answer to me is yes, but I do not believe that every single 49-and-a-half-year-old premenopausal patient with a micromet in one node should be told you need chemo. I think that so much of the endocrine ablation comes from the cytotoxic chemo. We don't really know the impact. I think the Oncotype was the right thing to do. There are a lot of groups in New York that if you're 49 and a half and you have a positive node, you're being told you need chemotherapy. The benefit is 4%, 5%. It's relatively small. It's a leap back to the 1990s when every woman with a 1 centimeter node negative cancer got chemotherapy. I think that the Oncotype becomes part of shared decision making, which I think is valuable. I'm guessing she would also get endocrine ablative therapy and an AI afterwards. So now let a real doctor answer the question.
So Genevieve knows the patient, so she knows the story.
And we commonly have these difficult conversations in the clinic. I mean, definitely what you're speaking to, a lot of us believe now that it is likely just the ovarian function suppression from the chemotherapy that's allowing for the benefit. And maybe it's not truly the chemotherapy, and that can be difficult because we don't have the data for that yet. So right now, the answer per the data we have that exists is chemotherapy is a correct answer, but this is certainly worth a discussion depending on the patient of shared decision making. If they're close to menopause, I certainly factor that in. What was their oncotype if they're lymph node positive, right? These are close to 26, and that gives me pause, but it's reasonable to have the conversation until that trial results, which is going to take years. That trial is ongoing now, ovarian function suppression, AI versus chemotherapy. That's going to be a really big deal. So you have that conversation with the patient. Chemotherapy is a right answer, but if that may not fit their goals of care and they may want to consider ovarian function suppression plus AI, that's not unreasonable, I think, also.
I have one more comment about Oncotype DX test in premenopausal setting. Because if you look at trial, most women are postmenopausal. The percentage of patient with premenopausal disease in that trial is very low. So of course we have to, in this case, extrapolate, so that basically, I just want to use a word of precaution in this, the use of Oncotype in premenopausal women.
So the story continues. Vera, any comments before we continue on, or? Okay. All right. So again, like everybody said, the RxPonder data, right? We can't use Oncotype data on a premenopausal woman that has a positive node. So we opted to go with another molecular genomic test on her. So we got an Agendia score on her, and her blueprint came back luminal type A. Mammoprint index was low risk. The probability of, again, we didn't consider pre-op chemo because she presented with node negative disease clinically, but it predicted 2% rate of a complete response with neoadjuvant. Absolute chemotherapy benefit predicted to be less than 1.5 based on the MIND-ACT data. And then the 5-year distant free interval predicted to be 98% with endocrine therapy. And she also was predicted to have a benefit of extended endocrine therapy. So does this change how y'all might manage the patient?
I normally do not use two, molecular signatures, because the question is, what if it's inconclusive to go to 3?
Say that again?
What if it's inconclusive? Do you go to 3?
Oh, tiebreaker?
Yeah, exactly. So, in fact, there is a study by Genomic Health that was part of it, where they look at the sort of a midnight score of the Oncotype DX. Then there's, I think, close to 200 patients. Then they were offered, a mammoprint. And guess what the result is? It's like 50%, it's like a flip of a coin, which is free, So that's why when I teach my fellows, if you have a questionable Oncotype DX test, this is now the time for you to put up your white coat and play doctor, and you don't, order additional tests. You use a clinical pathological feature to risk stratify. And
she was very motivated to, as most women are, to try to find a way to potentially defer chemotherapy without, potentially having a significant impact on her.
Sure.
And
But I definitely agree with you. It's muddy water, right? Now I'm trying to make a decision. I have more information. It doesn't always feel helpful. But I always agree with shared decision making with the patient, and depending on what's motivating their, what's driving their choices, and if this makes an impact on that, it could be important. And we know over time this is going to keep evolving, in terms of what tests we're using. And
so when I offered her Portacath or Mammoprint, she chose Mammoprint.
yeah.
And so she chose to defer chemotherapy and presented a tumor board. Also chose, we don't have a radiation oncologist on the panelists, but how do y'all feel? She also chose to defer radiation, one positive node, no extranodal extension.
Any radiation oncologists in the audience? Oh, good. No, I mean, the standard of care is to consider post-mastectomy radiation therapy if you have a positive node, and that's the standard. But I think that also becomes shared decision-making. I don't think it's dogmatic. We also don't order second genomic tests like you. I think that you've got enough information to go into this for a shared decision-making conversation with the patient. I think the further a patient goes from 50, the harder this gets. And I don't think I treat a 40-year-old the same as a 48-year-old, where I'm pretty confident in, ovarian suppression and AI. I will comment on the surgery. I love that radial incision, and our plastic surgeons hate it because they claim that it pulls the nipple areolar complex laterally. I don't think that's true. It also helps you on those cases where unexpectedly the major lactiferous ducts have DCIS and you need to go back and take the nipple. It's just a matter of extending that incision. There's a right patient and a wrong patient for an inframammary crease incision. And I would say while cosmetically they can be pretty good, it's not always the best oncologic operation. And so I'm a big fan of this. And then the final point I would make is that close posterior margin doesn't bother me if we did the case.
Correct.
If it's an outside operation and I don't know the surgeon, that might make me nervous enough to lean a little bit towards the radiation.
Yeah. There's almost always some muscle fiber on my specimen. Full fascia and a few muscle fibers.
I also want to add that with more effective systemic therapy, the trend is actually doing less. Less is better. That is the theme we have from last year's ASCO, and the same thing from the San Antonio breast cancer meeting in December. And there's a lot of study on how to omit, in fact, even radiation therapy. In fact, in this year's ASCO, 2 months from now, there will be a COMPASS study will be presented in the oral presentation and part of the authorship. And I cannot tell the result, but at least I can tell you less is indeed better, even for HER2 positive breast cancer. Dr. McKinney has a question.
I have a question since we were talking about surgery. Was there any consideration to performing less from the axillary standpoint? How many sentinel lymph nodes were removed when they came out and tested by frozen?
Just the one. She only had one sentinel node taken.
Because if you had done, that and not gotten anything back with a limited targeted axillary removal, then she would not have the morbidity associated with full axillary dissection.
Yeah. I use LymphoSeek and blue dye, so I almost invariably get one lymph node almost all the time because I inject as soon as they go to sleep. So I'd say 90% of the time, there's only one node that's blue and radioactive for me. Yeah.
Most of the time, but it wouldn't matter in her situation. You had a topical so you would not be showed up on.
No, she had nothing showed up on that MR or clinically. But there's no radiation oncologist here, but there is data. There's a multi-center cohort review on On one, yeah, and if there was one node positive, no extranodal extension, there was actually more morbidity from the radiation therapy than benefit. 2 was completely equal results, and then 3 there was benefit with radiation. So, yeah,
There's no question about that. And I think I hear your question too. So we use mag trace for the node, and actually we've used everything under the sun, and we've had the best success rate. It's injected while the patient's asleep. There's no pain from the injection. There's a very predictable number of nodes. When we used to use unfiltered 99 technetium sulfur colloid, I could get 6 sentinel nodes or 8 sentinel nodes.
Well, I use the lymphoseek, which it's a monoclonal antibody to the macrophages in the lymph nodes, so it's targeted, and so it gets there very quickly. And to me, it reduces morbidity of taking, 4, 5, 6 lymph nodes out, and so
no question. I think what you're getting at though is how much operation is right in the face of a node, and are you a breast surgeon? Yeah. So we've de-escalated more than anybody in the history of oncology. When I was a resident at Ochsner, there was a surgeon still doing radical mastectomies. And if you mentioned breast conservation, he would politely invite you to leave the OR and not come back. And so we're pretty good at de-escalating, and we're pretty good at accepting that, this is a staging procedure, not a therapeutic procedure. There's more pushback from the radiation world on de-escalation. In New York, maybe not here.
It depends on a lot of factors, right? Patient's age, the grade of the tumor, extranodal extension, how many lymph nodes. So it's all inclusive.
and there's more.
Yeah, I think that's right. The more surgery I do, though, and by the way, sometimes you take level 1 alone and you get 30 lymph nodes. Everybody's different in their anatomy. But the more I've done under the arm, the less I want radiation to touch that patient, because lymphedema rates are going to be sky high.
It varies also on the pathologists and their techs and how well they go through the sample, and so.
So Dr. McKinney, you're saying you would have done 1 to 2, you would have taken like up to 3 sentinel lymph nodes, and if only 1 or 2 were positive, you would have stopped. And that's what, per NCCN. Frozen. Right. Well, I do the same thing. I per NCCN guidelines, I sample 1 to 3 lymph nodes. If 1 or 2 are positive and the third's negative, I stop at the sentinel lymph node biopsy, and I don't.
What if there's only one that's a sentinel node?
I haven't encountered that. I use dual tracer as well, and I usually get at least 3 to 5 lymph nodes, which qualifies for a sentinel lymph node biopsy. I don't use lymphoseek. I use technetium and methylene blue dye. So I haven't encountered that scenario, but usually I follow what Dr. McKinney does, and it's in NCCN guidelines, and I usually save them from a formal axillary lymph node dissection and the morbidity of that.
And we're getting more and more, and we haven't talked about it either. I wish there was a radiation oncologist, but also molecular genomics is becoming more and more of a factor in making the radiation decision as well. Certainly with breast conserving surgery, molecular genomics are coming more and more. There's randomized trials to de-escalate radiation on a postmenopausal woman if they have a low oncotype score or a low mammoprint score now. It was added to the trial. Yeah, she was negative. Okay.
You reconstructed her at the same time?
She did. She had autologous tissue reconstruction.
She had a DEP flap?
She did.
Yeah.
And so the other thing, too, is like how I feel is, we probably did her surgery, I'd say October, November, and she's just now starting the endocrine therapy, which is probably the most important part of her treatment. And that's, I think we need to do better in maybe considering some patients, these higher risk women, for neoadjuvant endocrine therapy. I do believe that it is probably the most important part of her therapy, no matter what we do surgically or not.
There's a really strong movement up in the Northeast about not doing immediate DEPs, but doing a tissue expander placeholder. We're not always sure what they're going to get systemically. Sometimes it's more than others. We're not sure whether they're going to get radiation or not. You hate to bring in a DF flap and then radiate the damn thing. And so there's a real trend in New York especially to put the space holder in, get the patient through their acute treatment, and then go to the DF flap. And we love DF flaps. There are a lot of times where I like it better as a delayed than an immediate.
Yeah, we use a lot here, tissue expanders, and when they anticipate radiation. But she ended up not. She's going to also defer the radiation too, with the one positive there.
I'm assuming on a la soft and text, you'd give her ovarian suppression and an AI.
Yes.
And then we're using breast cancer index a lot for the second 5 years, so.
Just to go back to Dr. Borgen's point where he mentioned just breast conservation being like a forbidden term when he trained. I trained in Los Angeles at USC maybe 2 years ago. I graduated, and mastectomy almost became a forbidden term at one of the sites I was operating at because they were doing extreme oncoplastics, breast conservation, lumpectomies. And so I think it's just an interesting dynamic to take that into consideration. And just the recent data that has shown there's a slightly increased overall survival with breast conservation adjuvant radiation as compared to mastectomy that came out in the last couple of years, and just bringing that attention to patients.
It's interesting that it's definitely true. And we have a number of international faculty at the Miami Breast Conference, and the surgeons will say, well, we don't mention mastectomy at all to our patients. And I'm not sure that's right either. I mean, there ought to be a conversation about the risks and the benefits and the pros and the cons. And it seems overly paternalistic to say, I'm not going to tell Mrs. Jones about mastectomy because I believe in breast conservation. They don't know New York patients.
Right.
They come in very educated, and as your patients do too. And most places are probably 75, 80% breast conservation and 20%. And that's probably the right.
Yeah.
If you're at 95% breast conservation, it's probably not right.
We're in our region, we're probably at about 60, 65% here in New Orleans.
I think that's the sweet spot. I do.
Yeah, we counsel every single patient on breast conserving surgery. It's also mandated in the state of Louisiana, state law, that you have to discuss reconstruction if they choose and opt for mastectomy. All right, we'll go to another case. Okay, this is a 37-year-old woman who presented 17 weeks pregnant. She felt her own breast mass on self-breast exam about 1 month earlier when she was about 13 weeks. So I saw her when she was about 17 weeks. She was a G3P2. She had her first child at 33, and she was still actively breastfeeding her second child, who was about 18 months old when she presented. Family history, breast cancer in her mother, or at least all postmenopausal, mother, maternal aunt, and a couple on the paternal side, paternal grandmother and one of her paternal great-grandmothers. She had about a B, C cup sized breast with grade 1 mild ptosis. On her exam, you can palpate this mass in the kind of extreme superior right breast, about 6-7 centimeters from the nipple. No suspicious skin changes, no adenopathy. She was pregnant, and so no MRI, no mammogram. And here's the ultrasound image. You can see not too far from the skin, not too far from the chest wall, kind of in the periphery of the superior breast. She had an ultrasound-guided core needle biopsy. She had grade 1 invasive mammary carcinoma. ERPR both strongly positive, HER2 negative, KI 13%. So she had pregnancy-associated breast cancer while both being pregnant and while actively lactating. She had an oncotype, and her score was 18. And she strongly desired maintenance of breastfeeding, not only for the second child that she still was actively breastfeeding, but also the one that she would deliver in the future. So we did a right unilateral nipple sparing, again, through an inframammary approach. I took a small crescent of skin at the very bottom at the inframammary fold, and took about a 2 centimeter ribbon of skin at the inframammary fold, so it was lay flat. Because she was pregnant, we're trying to minimize surgery time. She was not interested in a tissue expander. She wants delayed autologous tissue later on. So I laid the nipple-sparing mastectomy flat on the chest with an inframammary fold incision. Just took a small amount of skin. And so, again, not interested in chemotherapy, wants to maintain breastfeeding for a time postpartum. So the question is, and her sentinel node ended up being negative. And again, we use radio tracer only. Pregnant women, we don't use blue dye, not proven to be safe in pregnancy. So radio tracer only. Sentinel node was negative. Ended up with the T1B clear margins, widely negative margins, stage 1 breast cancer. So how would you time her adjuvant endocrine therapy?
So I'd want to ask too, just because I'm familiar with this patient. I know initially up front, she said, I'd really like to wait till after I have the baby to have surgery. How the surgeons feel about that. And she's very agreeable once we discussed and educated her, but she was definitely angling for that. Like, I don't want anything until I have the baby. How would you feel if she waited that many months to have surgery?
No, I would have absolutely gotten her into the second trimester and done the surgery. I would have done the same operation. I would have used radio tracer, no blue dye, obviously. I would have done it exactly the same way if I could talk her into it. Not sure about that. But I would not be happy. And it's a low-grade small tumor, I get it. But if it's my daughter who's pregnant, I'm doing the mastectomy, no question.
Yeah, it was a very interesting case from the beginning because she's pregnant, so I was very concerned. She's lactating, she's still nursing her child,
So
and
we
she's
kept the other breast.
What's
and
that?
We maintained the other breast, and she maintained breastfeeding. She stopped breastfeeding just
Right.
perioperatively for 1 day around the day of surgery, and then resumed lactating on the opposite breast.
And from that standpoint, that she was thrilled. But just so worrisome to think about, you think about pregnancy-associated breast cancer and you assume this is aggressive, they have bad outcomes. That is what the data shows you. But what's interesting about that, when you look at that data, they don't look like her. They don't look a grade 1, strongly ERPR positive, low oncotype, lymph node negative with small primary. It's kind of the absolute best case scenario, which was a relief, and her oncotype being low. So timing for onset of adjuvant endocrine therapy, even though she's really young, you can feel comfortable with just doing a tamoxifen, doing a SERM. She doesn't per se need to have ovarian function suppression per the trial data that's available because she's not a high-risk patient. And in the first 6 weeks after the postpartum, of course, she's higher risk for VTE. Tamoxifen is a higher risk for VTE, so not giving it to her in that time frame, and it allows her to breastfeed like she wants to. So I'm going to see her back at 6 week mark. I don't know how she's going to feel about stopping breastfeeding or not. She understands at this point. She's happy to breastfeed at all for her second child, and understand it's not as practical to continue to breastfeed. And we've strongly encouraged her. That's not our preference.
It's a discussion
long-term
with the patient, informed, shared decision making. I think she's comfortable breastfeeding the one that she's pregnant with now for 6 to 8 weeks post-op, and then stopping that breastfeeding and not, going into the 1.5 years, and then starting her endocrine therapy 6-8 weeks after she delivers and stopping the breastfeeding.
Really just unusual.
Have you seen many cases, Pat, that a patient pregnant and lactating at the same time?
I work so hard to get the pregnant patients to my junior colleagues. I find it to be an emotional roller coaster, and this is a happy outcome, and it's just as often it's high grade, and
HER2 positive.
Right, exactly. So I think this was managed perfectly. Absolutely, I wouldn't do anything different.
I actually had. Go ahead.
I was going to say I agree. I've given chemotherapy to many pregnant patient. I'm happy to see that. Of course, this patient doesn't need any chemo, but if you do, of course, there are only few agents you can give during pregnancy, and that's basically in second, third trimester. So I think this is a happy ending for the patient.
Right. I think what you did surgically was appropriate. Obviously, we always say patients should have surgery within 3 months of a diagnosis. You don't want to delay care until after they give birth. I actually had a pregnant patient when I was in fellowship who had a second desired pregnancy, did not want to abort. She was just after her first trimester, so she entered her second trimester, and she had DCIS, opted to do a mastectomy with a direct-to-implant, and final pathology actually showed an invasive component, HER2 positive. So pregnant patients, usually you don't want to give Herceptin or anti-HER2, so the question came about, what do you do in those scenarios? Dr. Morange?
And like, did you do a sentinel node on her at the time?
I can't recall.
Because then it's so worrisome.
Yeah, we did. I think we did, and it was negative.
Yeah. I mean, she can't get HER2 therapy during pregnancy.
So there were actually, so I was a lowly fellow at this point, so I was researching all the things, and I was telling my attending there were some case reports, I think they were coming out of Italy, that showed they gave Herceptin to pregnant patients, HER2 positive, and they didn't see any long-term negativity to the fetus or to the mother. So I don't know what's come about that in recent research and data, but it was something 2 years ago, at least when I was a fellow, that was being discussed.
Right. I don't know of any updates on that, from the standpoint of a case report and talking to the patient about that. I still wouldn't feel comfortable.
I would like to comment, though. So it turns out that yeah, exactly. Ralph, our breast center in Brooklyn, in southern Brooklyn, is in the largest Chinatown in the Western Hemisphere. When I went to Brooklyn 15 years ago, it was the fastest growing Chinatown in the Western Hemisphere. Now it is the largest. And 1 in 4 of our chemotherapy chairs are occupied by a Mandarin or Cantonese speaking patient. We have the largest Fukienese speaking population also outside of Fujian province. Very often those require 2 translators. Fujian to Mandarin, Mandarin to English. That's fun. But with the small frame, relatively small breast size, we do a lot of nipple-sparing mastectomies, non-reconstruction, and the patients are actually very happy with the outcome. Mm-hmm. You don't have to, the dogma of I'm going to remove the nipple if I'm not reconstructing is not correct.
Correct.
And so we do this operation a lot, actually.
And it varies also plastic surgeon preference. I think they do get it if you leave a flat aesthetic closure with the nipple. And again, that's why I put her breast size. It was a B, a larger B, small C. So it allows the skin envelope to lay fairly flat. So there's not a lot of redundancy of the skin that scars down and fibrosis. There's one plastic surgeon says, leave all the skin, let it just fall there like a wrinkled up blanket with the nipple on it, and he unravels it. But most of them like to do that. And then if you radiate, and then, autologous tissue, but we've also done some patients that haven't been radiated that, like, for instance, she can get tissue expanded and then get autologous tissue to recreate the space, which is likely what we're going to do with her.
I just want to add about Herceptin and pregnancy. Placenta has larger pore compared to BBB, and there's animal data to show that exposure in vitro, to Herceptin may lead to cardiac development problem. So that's the fear. Although there's no kind of human trial, so that's why in general I do not give them anti-HER2 therapy, including TKI.
Okay. Well, I want to be respectful of everybody's time. It's after 4, so I want to thank everybody for their attention. Any questions before we break everybody out to the crawfish boil? Thank you to the distinguished panelists. Dr. Hendricks, thank you.